Great. So welcome everyone this afternoon. I want to just give everyone such a warm welcome today and to thank you for joining us this afternoon for this critical topic, infant food security in Canada. And it gives me great pleasure to be your host this afternoon. My name is Claire Gallant. I'm one of the parent partner co-leads with the Breastfeeding Committee for Canada on the National Baby Friendly Project. And it is really my great joy to be here today and to help lead you through this discussion that we will have in this presentation. So thank you so much for being here, and to the BCC, the Breastfeeding Committee for Canada, for producing in the back end and hosting this event. Just confirming, I do hear some background noise, so I don't know if everyone is able to mute themselves, or is that me? Hopefully it's not me. So just let me know, Michelle, if there's any concerns. And the slides are looking good? I assume they are. Okay, here we go. So I would like to take a moment here to recognize the land we are on before we begin and I share our agenda and presenters. So I myself am speaking to you today from my home office in the beautiful and abundant province of Nova Scotia, in the city of Halifax, Chipuktuk, and I'm on the ancestral and unceded lands of the Mi'kmaq people, where I'm very fortunate to be able to live and work and play. And last week I was reflecting on the National Day for Truth and Reconciliation as I went on a hike with my 3 kids, with another family in a local wood. And a friend of mine, my friend I was with, was saying how she liked the idea of talking about land appreciation along with land acknowledgement, and that really resonated for me. And I'm just so grateful to be an inhabitant here on the land. And I want to thank my colleague and friend Candy Edwards, who is the other co-lead, parent partner co-lead with the BCC, for her thoughtful crafting and sharing of this land acknowledgement that you see on your screen. We recognize that though we are gathering in a virtual way, our work takes place across the traditional lands of many Indigenous communities. We are thankful to be able to live and work in these territories. As we gather, we remind ourselves to respect and nurture our relationship to this land, give thanks to the First Nations, Métis, and Inuit people who have cared for these lands for generations. We encourage everyone at this gathering to learn about the Indigenous lands, treaties, and peoples in and around the places where you live and work across this country, to reflect on the enduring presence and resilience of Indigenous people, and to work together on building strong relationships that support systemic change. And I do think that the mention of system change leads beautifully into the introduction of our topic and subject today that we'll explore together, and the folks who will guide us through this discussion. Because this topic is really, it just looms large in Canadian society, infant food security. And I do think that when we talk about system change, and I reflect a lot about system change because it's dear to my heart, and I think that strong solutions can often be found with the conversations across borders and across barriers, and conversations across systems and communities, and bringing in all the players who are part of the story. And some of those players you will meet this afternoon. So my colleagues, parent partners, and people with lived experience, we have Kes Heaton and Charlotte Maloney, who are parent partners with the National Baby Friendly Project, and they're coach mentors with the team. We also have my colleague, Michelle Buckner, a parent partner who will speak on behalf of Breastfeeding Buddies peer support network today. And we have Dr. Sandra Hoy from Laurentian University, who will share some of her research. And you know me. And then I want to thank our advisors, Michelle Ledrew and Kathy Venter O'Grady, who are the directors of our national project. So welcome again, and I want to just go over what today's purpose is. So we have a few goals today for our work together and our afternoon and conversation. We're going to provide an opportunity for learning from parents' lived experience of breastfeeding and inequity. We're going to increase, hopefully, attendees' understanding of the evidence behind intersections of breastfeeding support and equity in healthcare systems. and offer resources and tips for supporting successful infant feeding for mothers and parents. And of course, all this is part of a conversation we'll have with you today. So feel free to share your reflections in the chat box, and we'll have some time for discussion at the end. So with that, we'll move into the agenda for today. So we're going to begin with Michelle Buckner's presentation, which is addressing human milk inequity and infant food security in Canada through peer support. Then Dr. Sandra Hoy will present the cost of suboptimal breastfeeding in Ontario, Canada, a health system costing study. Then we will have Kes and Charlotte, who will present protecting and supporting infant feeding, the patient's voice. Then Michelle will share a few words about our Coach Mentor program at the Breastfeeding Committee for Canada, and we will move into discussion and questions from all of you folks. So with that, I will hand it over to my colleague, Michelle Buckner, to begin.
Thank you so much, Claire. It's great to be here. I'm really excited to be able to share with you from Waterloo Region, Ontario, about our Breastfeeding Buddies program and what we've learned over the years about our peer support program and how human milk inequity is a growing issue and one that we think is really important towards addressing Canada's breastfeeding rates, human milk feeding, and parents' goals to meet their feeding goals for every parent. So I'm going to share first a video that is part of the Breastfeeding Buddies program, just to give you an overview of what our program is about. Breastfeeding Buddies is a community-based peer support program that has been active in Waterloo Region, Ontario since 2001. Breastfeeding Buddies aims to assist families to meet their breastfeeding goals through feeling connected and supported in their community. With a population of about 617,000, Waterloo Region includes 3 fast-growing urban cities and is surrounded by rural communities. Canada has a universal, publicly funded health system, and the Breastfeeding Buddies program is located within a not-for-profit community health centre. In Ontario, families want to breastfeed. Over 91% of mothers initiate breastfeeding in the hospital, but exclusivity and duration rates drop steadily over time, with only 33% of babies receiving exclusive breast milk at 6 months. Breastfeeding Buddies is a large peer support program with 147 volunteers. To become a buddy, a mother must breastfeed for at least 6 months and complete the program's 18-hour World Health Organization peer-based training. Buddies facilitate prenatal breastfeeding courses, and families can be matched by text, phone, or in person before or after their baby is born. The Breastfeeding Buddies community model relies on partnerships to connect with families facing barriers, such as young mothers, refugees, and parents using substances. In our view, breastfeeding rates are indicators of a community's success or failure in supporting families, not the individual failings of mothers. We offer strength-based, non-judgmental education and advocacy that aims to boost personal self-efficacy and informed decision-making. To grow and sustain a robust volunteer program, we have learned that developing mother-friendly volunteer opportunities that are flexible and include funding for childcare, food, and transportation is very important. We have also learned that building a culture of mutual respect between peer support and community-based leadership means more inclusive support. By using an evidence-informed model of training, peer breastfeeding volunteers are seen as capable and as credible sources of breastfeeding support. As a community leader in normalizing breastfeeding, the Breastfeeding Buddies program works within systems to make change and strongly believes peer breastfeeding support is essential in helping families reach their breastfeeding goals and ultimately creating a healthy, vibrant breastfeeding culture.
To listen, press first message.
One of the things when we're talking about human milk equity is recognizing that in Canada, babies that are born to white, middle-class educated mothers are the most likely to receive breast milk. This breast milk inequity, not anymore. This breast milk inequity is a social injustice that potentially has lifelong effects. And we've really noticed that in our role as peer breastfeeding supporters, that the individuals that don't fall into those categories often are not meeting their goals. So we have 4 Breastfeeding Buddies staff with diverse lived experience. And one of our main objectives is for people to be able to see themselves in our program. So of our 147 volunteers, we represent 19 different languages. And these volunteers come from really diverse backgrounds. So we have individuals that are as young as 19, as old as 60, who are new to Canada, who have experienced intimate partner violence, who have supplemented, who have breastfed a child or provided human milk to a child that they did not give birth to. And so that experience really speaks to reaching people that don't see themselves in those statistics of breastfeeding in Canada. Non-judgmental evidence-informed support is one of the foundations that we feel is strongly emphasized in our day-to-day interactions with parents. One of the things that we do know, and our program is in Ontario, but we do often hear from families across Canada, and a lot of these challenges are not just unique to Ontario, is that they often feel that there's an element of judgment or an element of a power imbalance when they're going for breastfeeding support to somebody that either is a healthcare provider or somebody that has a role where there's decisions that can be made on behalf of them. And so peer support is different. One of the things that parents often tell us is that they feel empowered when they're talking to another peer who can understand and relate to their circumstances. So one of the ways that we also deal with milk inequity through our volunteers is we provide childcare, food, and transportation for our volunteers and our participants. We want to make sure that there is no barrier to a parent meeting their breastfeeding goals. And so if that means getting them a taxi to come to our program, then one of the team will set that up. Claire, if you can keep on clicking. One of the other things that our team works really closely with our volunteers around is recognizing that parents need individualized support that is person-centered. So it's not a one-size-fits-all lactation recommendation. Each parent comes with a unique set of circumstances, a unique history, and their baby comes to them. Much like we all know, I have 3 kids and none of them breastfed the same. And so each parent needs a tailored kind of individualized support. Claire, if you can keep on going, that would be great. And then this really speaks to that systemic advocacy work, looking at systems that make it very challenging for parents to meet their breastfeeding or their feeding goals. And we're going to cover that. I'm going to share a few stories of examples. Next slide. So challenging existing power structures within the healthcare system, sometimes maybe sounds like really big words, but really what it's about is looking at the systems to find out whether or not they actually work for the people that need the help. And what we know as peers, and I put the pregnancy, breastfeeding, and cannabis comic up on this, is because often parents, mothers, breastfeeding people do not disclose something like cannabis use to their healthcare provider while they're breastfeeding or pregnant, but they do disclose it to peers. And so what we know is that healthcare power structure is really playing out in these situations. And so these families are not getting up-to-date, current, evidence-informed information because they're simply not telling their healthcare providers what they're actually doing. And this is playing out in many other harm reduction messaging around sleep, around milk sharing. Peers are seeing a lot of that out there. And that may not be something that they necessarily, as a healthcare provider, would be talking about. So we like to challenge those systems. Next slide. So this is Kate's story. Kate was a young individual. Claire, if you just want to keep on clicking, it comes up. She was young, pregnant. She was racialized, street involved. person that lived with her partner and in a motel. Kate was experiencing domestic violence. She had ongoing mental health and addiction issues, and she requested help from medical staff to help clean up. She was very, very successful at implementing methadone during her pregnancy. And during that time, she connected with one of our staff expressing a really keen interest in breastfeeding her baby. And this was something that she repeated many different times. When Kate's baby was born, she was encouraged by hospital staff to initiate breastfeeding or pumping. And the baby received pump milk while it was in the NICU. And when she was discharged, they sent home formula. And that was a suggestion based on just her circumstances. You know, when Kate visited her healthcare team after that, she requested breastfeeding support often. But the message that she got was she was encouraged to formula feed because of her circumstances. They used her, the social determinants of health and the barriers that she experienced as a parent as a reason for her not to continue breastfeeding. And she did not have an income to purchase formula. She didn't have anything to sterilize the equipment, and she was not shown how to safely prepare formula for her baby. And healthcare providers expressed concern that breastfeeding was just too much for her in light of the fact that this mom had expressed very clearly several times that breastfeeding was her goal and that there was actually no physiological reason why she wouldn't be able to continue breastfeeding. And so Kate was told eventually by her mental health provider that maybe it was better for her to let breastfeeding go. And they really honestly did not listen to this parent. And it was a really big struggle for her to reconcile that she never met her goals and she felt completely unsupported and honestly judged at every step of her journey after giving birth and while pregnant. Next slide. The other story is from a family, a newcomer family that gave birth to a second child in our region who had developmental disabilities. The father had very limited English and the mother had none. Despite many conversations without interpretation, so they, you know, fumbled through, they were told it was extremely unlikely that the baby would be able to breastfeed, and without listening to them, mom had successfully breastfed her first child. She put baby to breast and had initiated breastfeeding, and it was going quite well. The baby needed considerable amounts of follow-up appointments. The parents didn't have a car, so this was a family that got onto the transit system here with a newborn baby. And when they arrived at the hospital, it was during not the peak of COVID, but still when there were restrictions put into place. And when they arrived there, they were told that only one parent could come to the appointment with the baby. This was not clearly expressed to them prior to the appointment. So they chose between the two of them who could speak more English. At that point, interpretation was coming in and out of whether or not it was available. And when the father took the baby to the appointment, the mother walked around outside waiting to find out. As things happen in hospitals, and we can all appreciate this, something interfered with the scheduling, and this parent ended up waiting with his baby for 2 hours inside, and the baby started queuing to wanting to nurse, and a nurse fed the baby a bottle of formula without asking him or any kind of consent. If you want to continue, Claire. So they were extremely upset, confused. They could not understand why the mother was not called to be able to breastfeed the baby. They were extremely upset that they had no choice. At least that's how they saw it. And they absolutely felt that their rights as the parent of this baby and the voice of the parent was not heard at all. So social worker at the center encouraged them to seek out support around meeting their breastfeeding goals. And she contacted us, and there was a peer able to speak the language, and this parent then connected with them and moved on to be able to continue to breastfeed. But this is a really good example of systemic barriers that were in this situation that could have very easily have been alleviated by honoring the role and the voice of the parent. So just some of the challenges that we have encountered with peer support is more complex situations require more time. You know, one of the things as I'm writing grants is that it's constantly in the back of my mind, the quantity versus quality and the quantitative versus qualitative data. And one of the things when you are supporting individuals that have complex needs is that building relationships, trust with them takes time. And so it may not play out in the data, but the outcomes and the impact are huge. One of the other things that we've really encountered is just the general ignorance and about the importance of human milk, moral judgment, stigma, racism, ableism, classism. When it comes to breastfeeding, there are a lot of assumptions made about parents, and often breastfeeding is one of the things that goes first when people think that the parent isn't capable or competent to feed or parent their baby. And then really, honestly, one of our biggest things that we feel we'd love to challenge moving forward is the lack of upstream support for new parents. We really want to focus on what can we do preventively to get parents to be educated around their lactation, their bodies, their choice to breastfeed or not, and how can we move the dial forward with having that in place as a standard care practice for all clients, regardless if they're white, new to Canada, 17 or 51. Next slide. So just as a takeaway, what we've learned is that we also have really been working towards trauma-informed practice. A lot of our families will come to us with a journey that directly impacts their parenting choices and their ability to connect. Isolation has been a huge factor over COVID. I'm sure that's not unique to us. It's been felt across the world. But that an evidence-informed approach to breastfeeding support also really increases the credibility of the partner and the parent and the funding model. So when we look at peer support, we really want to be part of the team that supports people. We feel that a person that's choosing to breastfeed needs their partner or that support person in their life. They need their community. They need medical health care providers for those medicalized breastfeeding situations. And they need peers, other people, other breastfeeding people to be able to meet their goals. And that this investment is really worth it. We know that the outcomes for our children will be much better if we can get breastfeeding really well established for all families that choose to do so. So just Claire, if you keep on clicking, this is just a few ways for you to connect with us if you're interested in learning more about our programs, some of our social media posts, as well as a lot of our programs are virtually, and COVID gave us that gift that now people across Canada and quite honestly, the US, we have people coming all the time to our virtual programming. And then the next slide. It's just the contact information. So thank you very much, and I appreciate your patience with us having a few glitches, but Dr. Sandy Hoy will also talk a bit more about that inequity in terms of her suboptimal infant feeding outcome studies as well.
Thank you so much, Michelle. And yes, thanks everyone for your patience with us, and so glad we could share that important message and all those stories in there from parents and their experiences. And thank you so much for sharing that, Michelle. And I'm going to hand it over now to Dr. Hoy. And Dr. Hoy, if you would like to share your slides and let me know if you need any support with that.
Hi, everybody. My name is Sandy Hoy. I'm a professor in social work at Laurentian University. And I'm saying in social work because I'm presenting data today from a suboptimal cost analysis study that involves a health economist Michael Ona, who's not here with me today, as well as my colleague Kathleen Slafstra, but Michael is the health economist, so you won't hear a lot about the methods and the math. There's some slides about that, but I'm here talking about kind of why we did this study, what the results are, and I'm going to walk you through that today. I'm really glad to be here. This is the first time we're presenting this data. It is based on some work we've been doing over the last 2 years. We haven't yet submitted our manuscript for peer review, so this is the first time anyone other than our little team has seen it, but a paper will be forthcoming in the next probably 6 months or so. All right, so where am I? Well, I'm here, I'm at home today, but that's in what's now known as the city of Greater Sudbury, where Laurentian University is located, which is on the traditional land of the Titmashing Anishinaabe First Nation, as well as the Wanapitei First Nation. And the land where I'm at here is falls under the Robinson-Huron Treaty of 1850, a treaty that right now is not really being respected and is in the courts right now. The government of Ontario has taken this treaty, has taken the Robinson-Huron Treaty group to court, unfortunately, and it would be great if they could just settle and fulfill their treaty rights that I think they will be eventually forced to do through the courts. And I also want to acknowledge that I work in social work, a profession, I teach and work a profession that has significant involvement in the cultural genocide of Indigenous people in Canada, and there's special responsibilities for social work educators to talk about this, address this, and change how we are doing our work in social work. That is related to breastfeeding, absolutely, which Michelle just shared with us today. So I also want to acknowledge I have a partnership with Michelle Buckner and Breastfeeding Buddies. I'm also a former user of the program. I'm a breastfeeding mother of 2 that sought services 12 years ago. When I was pregnant through Breastfeeding Buddies, and really that relationship as a service user turned into a long-term relationship as a partner and kind of researcher and evaluator for the program, which is part of my work. And also thank you to the Lyle S. Holman Foundation, which has funded a lot of the work that Breastfeeding Buddies has been doing the last 4 years related to addressing barriers to human milk. And they provided us with the funds to pay for Dr. Michael Ona's time on this study related to the health analysis that you're being presented today. All right, so let's get started. Well, we all know this, right? This is why we're here. Human milk from the breast is the healthiest option for human infants. All other sources of nutrition pose some risk to child, maternal, and environmental health. And, you know, I just want to write, if you're interested in, you know, all of the kind of costing relationships and the costs and the risks of not breastfeeding, the Lancet series from 2016 probably is your best bet for getting more about that information. But here we are in Ontario, or I am in Ontario, and this chart kind of captures what's happening in breastfeeding rates throughout Canada, I believe. So this chart here just kind of captures, and you know, when I look across Ontario, for example, public health across units across Ontario often do feeding studies, and the same story kind of happens across those feeding studies, as well as the kind of national and provincial data. We have generally pretty good across the board initiation rates in terms of when you look at internationally. So in Ontario, that looks like 92% right now. And then we see this bad, not happy with drop happening at discharge from hospitals. So this is from Bourne Hospital data. And then we see, you know, the infant feeding studies that kind of look over time, you see week by week, you can see this go down. But for this data, we're looking just at exclusivity at 6 months being the kind of other point on this chart. But, and, you know, we still do see a good amount of people doing some breastfeeding at 6 months as well, but a chunk of people dropping off. So what do we know here, which is what Michelle said, is that, you know, families want to breastfeed. Things are happening that are getting in the way. And some of those things Michelle touched on, that we see inequities in the system. So we all, I'm not going to repeat what Michelle said, but I would also highlight we don't see very good rates within NICUs either. So you're even less likely to receive human milk if you are being born in a Canadian NICU, which is troubling for reasons that I will explore. So what am I talking about today? We're talking about, we did some economic modeling and looked at the costs of not breastfeeding in Ontario. And this is not anything new, which is what I just wanted to mention before we jump into the Ontario data, that there are other costing studies internationally. This one was a big one in 2019 that kind of pooled a whole bunch of cost studies together. They concluded that increasing breastfeeding to a near universal level could prevent 595,000 childhood deaths from diarrhea and pneumonia each year, reducing almost 975,000 cases of childhood obesity, and prevent 98,000 deaths from breast and ovarian cancer, as well as type 2 diabetes each year. They estimated that those health outcomes would cost the global healthcare system $1.1 billion annually, resulting in economic losses of premature child and women's mortality related to including 53 or almost 54 billion in future earnings lost. They calculated cognitive losses, which were estimated to equal about 285 billion annually, and then put a total big number. So the idea here, obviously, is the numbers are big, really too big to get our head around, that this is costing us a lot in lives, time, all of the things that they've calculated and put, health economists like to put numbers to. If you're interested in more about the costing piece, there's this tool that has available now. It's called the Cost of Not Breastfeeding tool, and this is the website that you can access it at. What you'll notice is it's a country by country exploration of the costs of not breastfeeding, and you can kind of toggle around and look at different rates and how changing the rates would save a certain amount of money or save a certain amount of deaths and cases. What you'll notice there is nothing for Canada. We aren't in this mix of the costing studies, at least right now. So other examples that I put in the slide deck of just international, American, UK cost analysis. This one from the UK by Renfrew is one that we based our cost analysis on for the most part. There's also some out of Australia and Spain, Netherlands. There's a bunch of costing studies that have looked at country-specific costs of suboptimal support for breastfeeding. A couple Canadian studies that kind of got at it that we looked at in our study. A Newfoundland study found that exclusively formula-fed infants had higher average costs associated with hospital admissions, family doctor, and specialist visits, and both excuse me, mixed feedings and exclusive formula feeding was predictive of higher total healthcare costs and service use. Another study kind of modeled the costs of mothers with HIV and breastfeeding and the cost savings if they were on the appropriate therapies and encouraged to breastfeed, but nothing that was kind of at the analysis level of some other countries that we had talked about up here. These are the only two Canadian costing studies that we were aware of. So what was our aim? We sought to estimate the costs of suboptimal breastfeeding rates to the Ontario healthcare system and model the healthcare costs savings if exclusive breastfeeding rates were increased. We aim to update the systematic review that was done by Renfrew and replicate their efforts in a Canadian context. We did start thinking that this study would be a Canadian study and it would speak to Canada. But it's just, we didn't have the resources to take that on. Canadian data is challenging to deal with. And, healthcare system being province to province, it was much easier for us to stick with Ontario. So we shifted from, a Canadian focus to Ontario. So what you're hearing today mostly is Ontario specific. Okay, so to our knowledge, no other study like this exists right now in Canada. Although you never know who's working on what. So here's what we did. We used public health agency, well, it's community StatsCan data really, but from public health, they gave us kind of the most updated stats related to exclusive breastfeeding rates at 6 months. And we modeled the current healthcare system cost burden and compared costs with scenarios of improved exclusive breastfeeding rates. So that means what we were looking at to see is what would be the cost, what is the current cost and the cost savings associated with if we were to maintain that beautiful 92% initiation rate to 6 months. Now that's kind of, shooting for the moon. But we also modeled maintaining the exclusive breastfeeding rates at discharge. So we wanted to see what, what cost savings could there be if in those two scenarios. So our methods involved literature reviews to identify the kind of epidemiological and cost input parameters, as well as the cost estimates. And our modeling focused on the 2019 live births and a hypothetical cohort of 100,000 women in terms of looking at the cancer stats. So I'm going to try and say this all in plain language here related to what we did. So first thing we did is we looked at another cost analysis study and used their review. And their review is what they were doing is reviewing all reviews of health outcomes related to breastfeeding. And so they did that up to 2012. We updated their review from 2012 to 2022. And the purpose of that was to find out what health outcomes we could feel that we could use if we were being very conservative, because Renfrew, their study was also very conservative in the health outcomes that they chose to model. And we also wanted to be very conservative. So we followed their kind of methods. We also wanted to look for searches specifically, or studies specifically, Canadian studies related to health outcomes and infant feeding. So looking for specific Canadian data on these health outcomes related to breastfeeding. We also did a review similar to Renfrew of just health cost analysis studies. So all of that together kind of helped us do this work. And then we went through a process that I won't go into detail on, but trying to find out, what health outcomes we would land on. And it was a whole process that's, Renfrew outlined in what they did. And again, just emphasizing this conservative approach. This involved the research team, as well as we had two consultations with Canadian researchers, specifically researchers that had experience with childhood asthma and childhood leukemia. So we went through this process of what do we include, what do we don't include. We really wanted to include illnesses that had the most robust evidence associated with breastfeeding. We had to include them outcomes where review studies were available, where it was possible to conduct the economic analysis based on what we had available to us in terms of the data. We excluded diseases where there was strong evidence, where there was a lack of strong evidence right now, where there were complicated relationships that were hard to model. That was the case for childhood asthma. So we did not include childhood asthma. Diseases where there were challenges with modeling were kept out. And when we had to keep the scope and feasibility concerns, which is one of the reasons why we stuck with Ontario. So here's what we ended up modeling, and I'm going to walk you through each one just quickly to give you the results. So we modeled lower respiratory tract infections, the costs of gastrointestinal infections, acute otitis media, necrotizing enterocolitis, child leukemia, breast cancer, and ovarian cancer. These are where, fit within what we had our conservative approach to the analysis. We also did some digging around breastfeeding rates, outcomes, and various things to come to this piece. So I'm not going to talk to you about our methods in detail, but I do have some slides about what economic modeling involves. And if you are interested in those, they're here for you. So what we were interested in looking at, again, just a reminder, is if we kept it at the current rate, if two scenarios, we modeled what it currently is costing us to have this 6-month 36% exclusivity rate. What happens if we were to boost that up to the discharge rate, 65? What would happen if we were to boost that up to the 92% at 6 months? And here's our economic modeling stuff, equations, things that I'm not going to speak to today. But here's the results, okay? So once we kind of put everything through the numbers and the equations, suboptimal breastfeeding Ontario results in potentially about 32,856 cases of lower respiratory infections that could be prevented through breastfeeding, possibly. That's what our cost analysis suggests. 27,500 cases of gastrointestinal, 39,000 cases of ear infections, 323 cases of necrotizing enterocolitis, 164 cases of childhood leukemia, 2,851 cases of breast cancer, 499 cases of ovarian cancer. Using, the REMFRE model suggests that those are potentially preventable cases if we were to be breastfeeding exclusively at 6 months. And then we put costs to that, which the numbers are below in terms of the cost to the healthcare system. And when you break it each down for each, we broke it down in more detail for you for each health outcome. So I'll just quickly go through those with you. But all of these numbers sometimes start to sound like a lot, but pediatric, so for the lower respiratory infections and hospitalizations, we know they pose a significant burden on families, households, and healthcare systems. And the available evidence suggests that about exclusively breastfed, the incidence of lower respiratory infections among exclusively breastfed infants was 25% versus 37% for formula-fed infants. We found in the research that there are clearly reductions associated with exclusive breastfeeding. And so using those risk ratios, we calculated that increasing exclusive breastfeeding at 6 months to the rate at discharge would save about 14,751 cases and 28,780 cases per annum in terms of if you were to, that's the 6-month rate. If you were to boost it to the initiation rate would be that bigger number, and then the discharge rate would be the smaller number. So if you were to boost it to those two, those are the differences. And then we would expect then results of fewer hospitalizations, fewer outpatient visits, and then savings in the range of $4.6 to $9.1 million in treatment costs. Similarly, we modeled gastrointestinal infections, again, looking at the two scenarios of if you were to continue breastfeeding at that high 92% rate versus that 65% rate. And again, we know that gastrointestinal infections are associated, reducing them are if you were to get a human milk, you are less likely to get gastrointestinal infections, less likely to be hospitalized. So we used some data to kind of come up with these numbers. We found that we would expect 2,700 to 5,300 fewer hospitalizations and fewer outpatient visits, resulting in about $9.4 million to $18.5 million in savings and treatment costs. Similarly, we know ear infections are one of the most common cause of healthcare visits and antibiotic prescriptions for children in Canada. And meta-analysis examining the relationship between ear infections and breastfeeding reported that exclusive breastfeeding during the first 6 months is associated with around a 43% reduction in ever having an acute otitis media in the first 2 years of life. So we kind of put those numbers through we calculated increasing exclusive breastfeeding rate at 6 months to the rate at hospital discharge after delivery and the initiation rate, and at the initiation rate would result in about 14,000 to 32,000 less cases, depending on if we're at that really high rate or that 65% rate. This would result in about 13,000 to 30,000 fewer outpatient visits for improving current rates, resulting in about $2.3 million to $5.5 million in savings and treatment costs. Now, just looking at necrotizing enterocolitis, so this would be infections, severe infections that infants almost, particularly low birth weight and preterm babies are very at risk for this, and it has a very high mortality rate. this infection. And we know this is one of the reasons that donor milk is made available, so that low birth weight and premature babies can get human milk to prevent this terrible disease. And so we also calculated how many cases could be prevented if we were to get more human milk into babies in NICUs in Ontario. And we calculated that it would save about 153 cases, 153 to 285 cases. That would result in $9 million to $17 million in savings in terms of the treatment costs. In our study, we did not model the costs of when there is a mortality, like when there is death related to a disease in terms of lifetime costs. That is something some cost analysis do, but we did not do that in our study. But again, if we were to invest in getting more human milk into people, we see that we would see some savings to the healthcare system. We also modeled childhood leukemia because this was one actually that Renfrew decided not to. They didn't have UK data. We do have Canadian data related to childhood cancer and leukemia and the relationship to breastfeeding. Some very powerful studies out of Quebec a number of years ago that were included in international meta-analysis, and we did reach out to the researcher who's involved with them. And there are some relationships that are pretty strong that others have modeled related to childhood leukemia. So we included that in our study. And we found that increasing rates, we could see about 63 to 89 less cases of childhood leukemia per annum, resulting in about $7 million to $10 million in lifetime treatment costs saved to the system. And of course, I'm talking about costs here to the system and not the costs to people, which I will mention at the end. Okay, breast cancer, obviously lots of 1 in 8 Canadian women will have breast cancer in their lifetime. 1 in 33 Canadian women will die from breast cancer. And this is a very strong relationship that's been developed that has been established in the literature at this point. Again, a relationship. We're not at the point where we are saying causation in any of these outcomes, but increasingly the data is pointing in this direction. Increasing the exclusive breastfeeding at feeding rate at 6 months to rate at hospital discharge and initiation rates could save about 952 to 850 cases of breast cancer per annum, respectively, which would result in $36 to $71 million in savings to the Ontario healthcare system. This one was personal for me because when I first started getting involved in breastfeeding and learning about breastfeeding, I have breast cancer in my family, and none of my family members breastfed. It was the first of my known maternal kind of relatives to breastfeed. And when I found this out, it really bugged me that this wasn't something that I knew about and wasn't something that is talked about enough, the relationship between breastfeeding and breast cancer. Ovarian cancer, similarly, increasing studies showing there's a relationship, and we similarly were able to calculate how many people, how many cases could it be potentially saved in Ontario, as well as the healthcare costs, which I've included here. So, when you put them all together, it's a big number. It's a lot of cases of illness that could potentially be prevented if we were doing better supporting people to meet their breastfeeding goals, which is what Michelle so beautifully talked about earlier. I want to just comment, that's a lot of just numbers and information sent at you, put at you in terms of healthcare cost savings. I think this data is good for advocacy. I hope it'll be used by people to continue to make the case of why breastfeeding support is so crucial. But of course, this is not the full story. We examined a limited list of childhood and maternal diseases, and we were pretty conservative about the ones that we'd included. We did not capture the costs of kind of emerging relationships between maternal diabetes in particular, because a lot of people are modeling that. SIDS, which we now are seeing even more data come out related to the relationship between human milk and SIDS, COVID-19, neonatal abstinence syndrome, obesity, and reduced intelligence. We did not include those in the study, but some others do. We didn't capture the cost of caregiver time that the higher rates of childhood illness requires. We did not calculate the environmental costs of non-human milk products. And it's likely impossible to capture the social emotional costs, including the attachment, bonding, and soothing benefits that are lost for infants and toddlers who are weaned early, or the emotional and spiritual costs related to the grief and loss some mothers experience over breastfeeding relationships that were never established or were dissolved before they would have liked. So these are all costs that we recognize that we didn't include here. We also didn't include the costs of just to humans having these illnesses and caring for people with these illnesses, what that emotionally costs, and the loss and related to life. We acknowledge that our parameters suggest associations and not causations. That is the nature of the breastfeeding and health outcome research. That is the critique that you will hear over and over again. And it's the reality that we don't have, experimentation related to human milk in the way that you can experiment with some things. It's not ethical. Our cost analysis are based on risk estimates of relationships between breastfeeding and disease that are potentially impacted by confounding variables. And we also want to acknowledge that the term prevention in the context of breastfeeding may be a misnomer. Human milk is a normal, biologically appropriate feeding method for human children. So some argue that breast milk does not actually prevent disease. It is actually the norm. So rather than other forms of feeding, it's rather the relationship is that other forms of feeding pose risks to human health. It is not breastfeeding that does much of preventing. It's the other forms that are promoting, that are causing the health outcomes that we're seeing. And reality is the real value of human milk is incalculable. We kind of echo some others' emphasis that we should be counting the value of human milk and the value of labor that goes into producing it, and recognizing this labor and recognizing the importance of human milk to the economy. So how might we do something about this to make things better? Well, for sure we know that people want to breastfeed. So how do we get there? Well, we have some recommendations here, but I think, Michelle really did a great job of how do we just support within the system people better to recognize the importance of human milk? How do we expand midwifery services? How do we do anti-racism and decolonization within healthcare systems so that people who want to breastfeed are not being stopped from breastfeeding because of who they are? We would like to see increased access to donor milk for infants in the NICU, and of course, the enforcement of the International Code of Formula Marketing. Final note for our little presentation was just that, like Michelle said, we don't see suboptimal breastfeeding rates as an individual failings of mothers or their infants. There are real, often unseen systemic barriers to effective breastfeeding supports that have developed over time and have yet to be undone. We want to see the cost analysis hopefully continue to emphasize to people that make decisions that there's investing in supporting families to breastfeed is a smart way to use our tax dollars. So that's it. Thank you, merci, and Chimigwich.
Sandy, thank you. Thank you so much for that absolutely fulsome presentation. And wow, the data really does speak volumes. And I noticed that you said keep an eye out for the final presentation. We did have a request in the chat for you to share the paper, but I assume that given its draft form, it's not yet shareable. This is the initial sharing with this group. So yeah, maybe we can keep in touch with you.
Review still, yeah.
Yeah. So yeah, we'll maybe be sure to send to keep an eye for that and to connect. If anyone would like that final paper, we can work to spread the word once it's published.
Yeah, absolutely. Thank you.
Thank you, Sandy. So now we will, I will pull up the slides for our parent partners, Kes and Charlotte. So just let me share that. And I'm seeing some great comments coming into the chat and really thoughtful messages. So we'll be sure to get to that in our discussion section a bit later on. Is that coming up for everyone? Kes and Charlotte, are you all set?
I'm ready.
Great. So I will hand it over to the two of you. Welcome, Charlotte and Kes.
Hi, everyone. I think this is a great segue. I loved hearing a lot of the numbers and things like that, and then being able to sort of now bring it over to the patient parent side of it. Sorry, I'm not seeing the slides, so I just got to click on them. Okay. So I'm Cassie Heaton. I'm one of the parent-patient partners with BCC, and I am lucky to be presenting from the land where I was born, in the town of Ladysmith, on the ancestral unceded land and unceded territory of the Semanis First Nations. And then Charlotte.
Hi, I'm Charlotte. I'm another parent partner coach mentor, and I am in Ottawa, which is on unceded Algonquin territory.
So we're presenting today on protecting and supporting infant feeding and the patient's voice. So you can change slides. So as patient and parent advisors, a lot of us come from volunteer roles. So we've had either an experience as a patient or a parent, and we have a goal to work along with healthcare providers and the community to help either bridge learning, bridge gaps, work as a liaison, be a voice for parents based off of our own experiences, without any other agenda other than to sort of just be that bridging voice so that the delivery of care meets the needs of the patient's parents and babies. So medical, social, and personal factors may influence an individual's decision on infant feeding methods. And so it's just bringing some of that experience and voice on how to hear the patient, hear the parent, and make sure that the delivery of care meets their needs and meets them where they're at. And that because providing human milk can be challenging, especially in the early weeks and months, just meeting those with sensitivity and making sure that the parents are supported in their decision, and that we are making sure that healthcare providers and the care teams are making sure that they are well informed and they are delivering informed information to those parents, and those parents are feeling safe and respected. Also making sure that that information is sort of continuous information across care, and that the support is reliable, because it plays a huge role in the success of breastfeeding and chest feeding.
So in terms of our goal is to improve perinatal practices and healthcare experiences by promoting person-centered care. So that includes voicing recommendations and insights from the viewpoint of parents and patients, as well as working collaboratively with healthcare professionals and community support workers to help formulate practices in manners that enable parents and patients' voices to be heard and considered. So this involves collaborating with leadership and healthcare practitioners throughout all levels of the health system in order to support both parents and care providers. Next slide. So we believe it is important to involve all appropriate parties in this very special journey, as this process looks different for different families and babies. So every family's journey is unique, but nobody's journey should be alone. Next slide. So we're going to talk a bit about our experience as parent partners. So for me, I began my journey as a parent partner a little over 9 years ago after my first child was born. I joined a quality improvement committee at the hospital where she was born in the obstetrical unit. And I was very excited to join, but I was also very nervous and intimidated. I don't come from a medical background, and I was coming into this room with all of these professionals, but they really were so welcoming to me. They, had a standing item on their agenda for me to share anything about, anything that I had heard during the meeting, as well as anything I was hearing from families in the region. It was really a wonderful experience to sort of show me, that behind the scenes of the healthcare system, and then really try to integrate the patient voice into that. Some of the things that really helped me feel valued is just, allowing me to bring my children with me to meetings. I was always welcome to bring my babies with me and, breastfeed throughout the meetings. They provided parking passes and made sure I knew, where the meetings were being held. And it was just really such a wonderful environment to begin my journey. And from there, I joined a few other regional committees, one of which I'm now the chair of, a family advisory committee, and a few other work groups. And through that, I sort of began navigating that sort of in between the healthcare system and patients and families. And I really learned, just so much about how the health system works, and really seeing how much the people that work in it care, and some of the challenges that they face, and then also learning, how to present that family voice and how to get it to be valued, and to just show how important it is to have families involved, in the decisions and all of the different processes. So it was really, it was a wonderful journey for me, and I hope that I'm able to continue. And things in the 9 years that I've been doing it, things have been getting better and better. It's, more and more parent partners have been involved, and it's really becoming something that's less of, just a checkbox, and really integrating parent partners into every aspect of the healthcare system. So yeah, that's my experience as a parent partner.
Claire, can you just click forward 2 slides for us? And one more. That was it. Perfect. Thanks. So I had a bit of a different experience. I was lucky enough to have grown up around healthcare providers, and my mom was a nurse. And when I was in high school, I had done a sort of test. What do you think you'll be when you grow older? And a doula had come up, and I thought, what was a doula? And I looked into that, and then I came up with a midwife, and what was that? And so I was lucky enough to go through my last year of high school job shadowing a midwife. And so I had all of this sort of unfounded courage into going on a breastfeeding journey when I was going to have kids. And it was sort of, I guess not everyone who's in attendance today may have ever had experience with infant feeding personally or anything like that. But one thing that we all do have experience with is switching to this virtual world, this working online and things like that. And much like a breastfeeding journey, you go into it sort of, you can be one end of the spectrum or the other terrified or thinking this is the best thing ever. You could have 3 children at home, an ailing parent, and be working in a different time zone where you have to get out at odd hours to work online, or you could be at home just you with your cat and only work 5 hours a day. But one of those things that we all need in that journey of learning something new is the information to be able to do it, the support, and the resources, right? So for me, I'm a mother of 3. I had 3 very different breastfeeding journeys. And my first one, I went into it very confident. I had quite a great support system. I had midwife. I was lucky enough to live in an area that provided care at home after. There was a nurse who came and saw me. And I really wanted to get out of the hospital as fast as I could after my first child, because I felt confident that the support was going to follow me there. And I had read everything that was available. And I was lucky enough to have a baby that, latched great and everything like that. And I would have labeled that for myself as a successful breastfeeding journey. Fast forward to my second child. It was a much different experience. He had some difficulties. I had some difficulties. I now had a small one at home, and I did feel a little bit rushed. I felt like that because I had a child already, I hadn't been given as much information. I'd forgotten some of it, and this was a very different baby, and all of the things that I'd been trying with my first weren't working with my second, and I felt a little more lost, a little less informed, and a little less supported. And it was in that moment that I realized, through trials and tribulations and ebbs and flows and trial and error and pain and things going through with my second, that I had to quickly decide what success meant for me, right? Success with my first was getting to a certain stage of nursing and weaning and things like that. And with my second, I kind of had the mindset of like, as far as we can go is success for us. And I think that with working with the patients and care providers, it's bringing back, remembering that we're trying to do this journey together, and that we have to realize that success for each person is very dependent on their situation. And then fast forward to my third, was probably one of my hardest experiences, because I was, a mother who had 2 previous children already and 2 successful breastfeeding journeys. And I was given little to no information whatsoever. And once again, was met with a different little person altogether who did it quite differently than the first 2. And I tried to stay in the hospital as long as I could, because I just felt lost and scared. And I had just undergone a recent diagnosis that was going to affect my breastfeeding journey. And then I was faced with a care provider who, I think that they had the best of intentions, but gave me a small cup and said that I had to fill a certain amount with colostrum to prove that I was producing enough milk, or they would give the baby formula. And at that point, I was so exhausted. I just felt defeated in that moment, and just thought, what if this had been my first experience? What if I was given little to no information, very limited support, and feeling like I wasn't measuring up right from the beginning? Would I've ever breastfed any of my children going forward? And I was lucky that I had actually joined working with the Mickey program with Fraser Health, and as a patient partner just a month before giving birth to my third. And much like Charlotte, they welcomed me with open arms and a new baby to support them. And for that month before I'd attended my first meeting, I felt absolutely defeated. I felt like that one experience had changed my whole outlook on it. And I didn't want anyone else to feel that way. And to be able to sit down with a table of care providers and see just how many people, like the people who are in attendance today, really are behind helping this initiative move forward, helping support parents and infant feeding. Because like we've seen with Dr. Hoy, the numbers are there, and we can't put a number and we can't put a value really on the things that aren't measurable, and what that means in our care system, and being able to support parents and support infant feeding. And so as patient parents, we sit at that table to bring that voice, to bridge those numbers, to bridge those ideas of success with what is happening in individual homes. And even with just the release just recently with the new health feeding guides of breastfeeding to the age 2, it was so funny, because even though I would say that I breastfed for a great amount of time for myself, I instantly felt for a moment, oh, maybe I'd failed, maybe I hadn't gone far enough. And then remember that it looks different for everyone. So just having that voice at the table, so that the messages from the care providers, because a lot of work and effort goes into it as health care providers, to do the best, to be able to relay those messages, that they're falling on ears in the right way, with the right language, understanding some of the real barriers that some people are against, and making sure that the parents aren't feeling defeated, and that the best information is being shared from the forefront throughout, and making sure that it's safe and reliable care. And just helping people remember that success is whatever they can do, and whatever they, and just being there for whatever they need. So it's been such a joy to get to work with the BCC and work with BFI to help that care be continuous, sort of across the board, so that no matter where in Canada our parents are going to have their babies or have them cared for, that there's that standard of care, that standard of support, and that understanding of what we need to do going forward to get some of those numbers up and get that support increased, and make it so that parents are going in informed, and healthcare providers are feeling like they are providing everything that they can, and it's being received in the right way. So, sorry, next slide.
Sorry, can I jump in? Claire, could you just go back 2 so I can do my story?
Oh, sorry.
No, that's okay. Perfect. Thanks so much. Sorry about that. So much like Kes, I think it's such an important thing to define what success means. What is a successful breastfeeding relationship? For me, I considered a successful breastfeeding journey a journey that started and ended when I felt like it was right for myself and for my child. So for me, I breastfed all three of my children for over 2 years, including during 2 of my pregnancies. And so for me, I would say that I've had 3 successful breastfeeding journeys. And that's something that I was able to achieve because of my circumstances and because of the care that I got from my healthcare providers. So really starting prenatally is, having those discussions, getting that information, even though, it's always sort of a shock when you have your first baby and you have all this information that you've heard before, and it's sort of, you can never fully know what it's going to be like in the moment, but just having those discussions prenatally with my healthcare providers was just so beneficial. And, I was very fortunate that my healthcare providers were knowledgeable with best practices. So for all 3 of my babies, we had immediate skin to skin. They were with me for, a long time right after the birth. All every exam and test they could do with the babies on me and nursing, they did. So that was just wonderful that, that was their standard. So that's what I received just for all 3 of my births. And then the support I received from them was just phenomenal. So that support when things are tough, right? So with my first baby, any latch difficulties, just having my midwives come to my home and sit with me and help me. And they were so calm and reassuring that even, when I wasn't calm, they were there to just support me. And that really made such a huge difference because, I didn't feel like giving up and I didn't feel like I couldn't do it. I really felt like, okay, this is something that we're going to work through together. So that had such a big impact on my breastfeeding journeys. And again, having built that relationship with them prenatally all the way through the birth and postpartum, I really trusted them. And I felt like they knew me and they knew how to help me and they really saw me as an individual. Like I mentioned, those home visits were so amazing. So I had the privacy to breastfeed in my own home and get the support that I needed postpartum. And so when I look back at my breastfeeding journeys and how, they were successful for me, I really have to acknowledge, all the privileges I had. And we heard Michelle talk about this earlier. I had, access to these healthcare providers. I had access to a birth center where I had a private room. I had the ability to get information and care in my first language. So I didn't have that barrier. As someone who wears hijab, it was really wonderful to have, a private room where I could, be free and know who was going to be coming in and out of the rooms. And that was great for skin to skin after the birth and to breastfeed. So, I had that privilege of having insurance to cover a private room in the hospital or just having access to the birth center for my second 2 children where they were born. And then, just the privilege of I was able to stay home with my children and be financially supported so that breastfeeding journey, I knew that I could have my babies with me, wherever I was, and I was able to work on that breastfeeding relationship. And that is just such a huge privilege that I have to recognize. And so I really think that, that reliable care that I got, there's just the supportive healthcare team that I had, and the fact that they were, I was getting clear, accurate information really, really led to me being able to have 3 successful breastfeeding journeys. So, if you could go forward. Yeah, one more slide. Kes, did you want to
Sorry, I was still muted. So the keys to success in our eyes as patient partners is information. So making sure that we have reliable information for everyone that's consistent, that is information that is known to the care provider and then provided to the patient. One of the things that we're hoping to see is having some of that be just more consistent all across Canada and in sort of up into the north, and just seeing that that information and contact is available. Along with that contact brings us to support. What support is available in the area, what support is available beforehand, during, and after for your breastfeeding journey, and that the care providers are also aware of that support. And then reliable care. So just that feeling of safety, that there's diversity and inclusion for the people attending, like Charlotte had mentioned. Everybody, we come from such different backgrounds, different walks of life, different comfort levels, different abilities, and just making sure that that attention to that reliable care for safety is just one of the most crucial portions, I think, in the infant feeding journey, is just being able to have that feeling of trust, whether this person has had 1 child or 5, or this is adopted, or whatever the situation is, that the care and support there is there, because it is such a challenging experience. And as soon as you think you've got it, something changes and maybe you don't, or something changes, and you can have successfully breastfed your first 2 and then wake up one night and have no milk and not know where to go from there. Who do you call on? What information do you have, and who do you have as a care provider? So we're really, really blessed to be able to be at the table, to have that voice come to the table, because even for care providers that are parents that do have children or who have gone through that journey, times change. What you might believe is available in support might not exist anymore in that area, especially through COVID. There's a lot of people going forward who believing, from my first to my last, I was really sad to not have that public health nurse come by my home. I needed it more than ever on the 3rd child than the first. And some care providers were unaware that those weren't still available, right? So just making sure that we're up to date with what is actually available in that care. But yeah, mostly just us having a voice at the table really also helps us share with other parents who have had not a great experience, or who have had a great experience, to appreciate that there are people at the table, there are people working behind the scenes to try to make this just a safe and inclusive environment to be able to support this initiative. And if you'd like to reach out to us or contact us or have any questions, this is how to reach Charlotte and me.
Thank you so much to you both. And, it's just so important and so wonderful to hear your stories and the detail you shared about your experiences, and just so interesting, so many nuggets of real and true wisdom. I mean, just Kes, to hear about the sort of arc of your 3 and what was offered to you and what was not, and just that reminder that everyone does have such a unique outlook, right? And that the assumptions and that are often made can are not always useful. And I'm thank you both for sharing, and I think we seem to have a lot of mothers of 3 on the call today, and I'm one myself, so it's just a privilege to hear what you have to share, and thank you so much. So we are nearing the end of our time together today, and I'm just going to invite the wonderful Michelle Ledru on, one of the directors of our Baby Friendly project, to just give a short outline of our Coach Mentor program, which Kes and Charlotte are such a critical part of, and as well as Michelle Buchner, and just to speak a bit on behalf of the Breastfeeding Committee for Canada about this program we have on right now. Michelle, feel free to take the floor.
Great. Thank you, Claire. Can you just make the slide a little bigger? I'm just seeing it as a small slide right now. But thank you so much. Awesome, fantastic presentations, and it really showcases the importance of having appropriate systems in place, whether it's income systems and the EI supports, as Michelle Buckner mentioned early on, having the appropriate health systems and peer support. And then it's so great to know the emerging data so we can use that information as advocacy to help build the case that, you know, this is important work and it impacts not only the costs, but it impacts the actual outcomes and health of the individuals and families. So being part of the breastfeeding community for Canada, myself as the national project director for the Baby Friendly Initiative related to the quality improvement projects that the BCC has been doing, I'm also co-chairing that role with Kathy O'Grady-Venter. Kathy couldn't join us today, so Kathy's actually leading this coach mentor program, and so I'm speaking on her behalf. But the Baby Friendly Initiative program has been around for a long time, decades in fact, but we seem to struggle with implementation of the Baby Friendly Initiative in Canada. And we've received funding from the Public Health Agency of Canada to further scale up and implement the Baby Friendly Initiative in Canada. We did a national project with 25 hospitals across Canada over 30 months. And now we're into this phase, which we're calling a coach mentor phase. So we're taking the lessons learned that we had from the other teams that were involved in using quality improvement strategies to implement best practices. And so this is another form or another way that the health system can respond to the needs of families to meet their breastfeeding goals. And so what this program does, it'll be offering up a coach mentor that has expertise, passion, knowledge, and skills related to quality improvement, Baby Friendly Initiative, and breastfeeding. And then they're matched up with a facility, whether it's a hospital facility or a community health services facility, to be able to help them along their baby friendly journey and implement best practices. So because of the funding from the Public Health Agency of Canada, it's really great that there's no cost to the facilities. And using strategies of quality improvement are also recognized as best practice and helps build interprofessional teams so that they can all work together through common goals. And I think one of the main things we're most proud of with this program is the engagement of parent partners, and not just being engaged and sitting at tables, but leading, as you've seen today with the parent partners who are presenting today, and leading the change and the work that's needed in the health system. So it's extremely valuable. So the ask of you today is really to share this great program. That's you can get more information about it on the Breastfeeding Canada website. So just go to breastfeedingcanada.ca, and you can find out more information about the Coach Mentor program. And please share it with your local facilities, share it with any networks that you have, whether it's social media, so that hopefully others can take advantage of being supported along their journey towards evidence-based practice and baby-friendly initiative. So thank you all. I'll kind of, you click to the next slide there, Claire. We're nearing the end. I'm in the tail. And so we just have a very, very short evaluation of this webinar today. It's just 3 questions, so it should only take you a couple minutes. I'm just going to post it as soon as I finish talking here. I'll post it in the chat box so you have the link. But please share your feedback about what you've heard today. And I just want to say, before I hand it back to Claire, a special thank you to Claire and to our planning team, which included our parent partners who spoke today, Charlotte and Kess, Michelle Buckner, and also a big thank you to Dr. Sandy Hoy, who presented her emerging research. So you saw today the excellent contributions of our parent partners. And I'll hand it back to Claire to say the final closing words here.
Just another really broad thank you to all of you for joining us today and for sharing all of your comments in the chat and having this discussion. Thanks to Charlotte and Kes and Michelle and Sandy, and to Michelle and Kathy, our fearless directors. And we have happy National Breast Chest Feeding Week, everyone. And so thank you so much. This has been a great afternoon. It's been a great week, and really appreciate your attendance today. So thank you so much for being here, and we will close it out here. Have a great rest of your week.